Today we will be having a discussion on ECG in hypertrophy and bundle branch box. In the last discussion, we have discussed about how to interpret an ECG and what are the basics of an ECG. So let us start the discussion. In our last discussion also, we have discussed how to look for left atrial hypertrophy in an ECG. So for left atrial hypertrophy, we will look at lead 2 and lead V1. Okay. So in lead 2, if there is left atrial hypertrophy, there is this prolongation of the P wave along with this notching will be present there. The normal duration of P wave is less than 2.5 mm or less than 0.1 seconds. Okay, so if P wave is more than 2.5 mm width in lead 2 or duration is more than 0.1 second, then it is called as wide and bifid P wave, which is there because of left atrial hypertrophy or left atrial enlargement, which is also known as P mitral. So this part we have discussed in our last section too. In lead V1, the normal P wave is this biphasic. That is, there is a upward deflection due to RA and downward deflection because of LA. And each deflection is of 1 mm, less than 1 mm. Okay. So in LA hypertrophy, the upward deflection would be normal, but downward deflection would increase, and the downward deflection size would increase, and it would be more than 1 mm now. Okay. So this is how we look for LA enlargement in ECG. Now let us discuss about RA enlargement. So in RA enlargement, again we will look for lead 2 and lead V1. Okay. So in lead 2, there would be tall P waves. So the normal height of P wave in lead 2 is less than 2.5 mm. If it is more than 2.5 mm, it represents RA hypertrophy and it is also known as P pulmonale. Similarly, in lead V1, have this biphasic P wave, and if upward deflection is more than 1 mm, then it represents right atrial hypertrophy. Yes. Then we have this ECG criteria for LVH also. So first of all, it is very important to know that ECG is relatively specific but lacks sensitivity in diagnosing LVH in middle-aged males. Why so? Because due to like obesity or increased muscle mass, the QRS complex won't meet these criteria, but still there would be hypertrophy. Okay? So due to this, there is decreased sensitivity, but yes, they are relatively specific. Okay. Now we have these 4 criteria for diagnosing LVH in an ECG. The first and most important and most commonly used criteria is Sokolov-Lyon criteria. Okay. So in this criteria, just give me a second. Okay. So in this criteria, we measure S in V1 plus R in V5 or V6, and their sum should be equal or more than 35 mm. Okay. This is first component of this criteria. And why this occurs? Because suppose this is a heart and this is left ventricle, this is lead V1, this is lead V5 and V6. So when there would be hypertrophy of left ventricle, the S wave in lead V1 would become more deep, and R wave in lead V5 and V6 will become more tall. Okay, so this is why the S wave, since S wave would become more deep and R wave would become more taller. So their sum would become more than or equal to 35 mm. Second component of this criteria is R in avial should be equal to or more than 11 mm. Okay, so this occur also because of the same reason that since avial lead is somewhat like here, this is the avial. So avial lead would record a more upward deflection. Now we have the second criteria, which is known as Cornell's criteria. This is Cornell's criteria. The Cornell's criteria states that R in avial plus S in V3 should be more than equal to 28 mm in males or more than equal to 20 mm in females. So this is the Cornell's criteria. Now we have this third criteria, which is known as Romhild-Estes points system score. This is a score containing various components. We don't need to go into detail about them. But yes, if the score is more than equal to 5 mm, sorry, more than equal to 5, there is high probability of LVH. Clear? Now the last criteria is Roberts criteria, which states that the height of QRS in all the leads should be equal to more than or equal to 175 to 225. This is the last criteria. Yeah. Then next slide is STT changes in LVH. Okay, so the next thing is STT changes in LVH. So in LVH, there is hypertrophy of this left ventricle. And we have these leads like V5, V6, lead 1 and lead AVL as lateral wall leads. So what will happen that when there is hypertrophy of this left ventricle, the muscle mass of the left ventricle would increase. In normal myocardium, the depolarization occurs from endo to epi, and repolarization occurs from epi to endo. But now, since there is hypertrophy, the depolarization would go from endo to epi only. But before it reaches the epicardium, the repolarization should start. So repolarization should now have to start from endocardium only. Okay. So the direction of repolarization reverses in the hypertrophied wall. So due to this, in the left wall of the ventricle, the direction of the repolarization reverses, leading to the T-wave inversions in the left ventricular lateral wall leads. So we would be having these T-wave inversions in V5, V6, lead 1 and lead AVL. This is known as a strain pattern. Okay. One thing which you should know is that we have these two types of hypertrophy. One is pressure hypertrophy, which is also known as concentric hypertrophy. And another one we have is volume hypertrophy, which is also known as eccentric hypertrophy. Okay. So in pressure or concentric hypertrophy, this strain pattern would be seen. While in volume or eccentric hypertrophy, since there is no increase in the width of the myocardium, there would not be strain pattern. Okay. Here. And these T wave inversion may be associated with ST depression as well. Clear? Now let us come to the next slide. That is, what are the causes of LVH? We have many causes of LVH per se. So anything that would increase the load of LV, that is afterload or preload, would lead to hypertrophy. Okay. And if afterload is increased, then there would be pressure hypertrophy, and if preload is increased, then there would be volume hypertrophy. So the first and most common cause is systemic hypertension. Here, another cause is AS, aortic stenosis. Another cause is AR. Another cause is MR. Clear? Another causes are HOCM. Okay, and ET. We have these many causes of LVH. Clear? Palpitation of aorta. Now look at this ECG, and we'll try to apply all the criteria in this ECG. So this ECG is it presenting LVH. So first of all, let us apply this Sokolov criteria. The first component of this criteria is S in V1 plus R in V5 or V6 should be equal to or more than 35 mm. Clear? So this is S in V1. It is 1, 2, 3, 4. Almost 4 big squares, that is 20 small square, that is 20 mm, plus R in V5. R in V5 is 1, 2, 3, 4, 5, 6. 6 big square, that is 30 mm. So it is 50 mm. It is satisfying this criteria. Second component of Sokolov level is AVL. The R in AVL should be equal or more than 11 mm. So R wave here is of 15 mm. So it is satisfying both of the component of the Sokolov level. Another criteria we have is Cornell's criteria, in which we will add the R in AVL and S in lead V3. So we have this 1, 2, 3, 6, 7 big squares are S in V3. So R in AVL plus S in V3. It would be 15 plus 35. It is 15, which is much greater than 28. So it is satisfying this criteria also. Also, when we look at this ECG, you can see that there is ST depression and T wave inversions in lead V5 and V6. So this is known as strain pattern. This is a pressure hypertrophy. Also, there is ST depression with T wave inversion in lead 1 and AVL 2 because all these fours are lateral wall leads. Clear? Now the next slide. Again in this ECG, one thing we have skipped is that in the last slide, we can look at this ECG that the axis in this ECG is left axis. So from my first class only, we know that how to look for an axis. So the axis in this ECG is a leftward axis. So most of the time LVH is associated with left axis deviation also. Because when there is left axis deviation, suppose this is the heart. If there is left axis deviation, the direction of major ventricular depolarization would shift to this side, leading to the leftward axis. This is the next slide. In this slide also, let us try to apply all the criteria. First of all, Sokolov criteria. So S in V1 is approximately 3 ppb square, that is 15 mm. R in V5 is 1, 2, 6, 30 mm, 45. So it is satisfying this first component, but R in AVL is only 5 mm. It is not satisfying the second one. But if it will satisfy one component only, we can say that there is LVH. Now we can apply this Cornell's criteria. So R in AVL plus S in V3. R in AVL is 5 mm, S in V3 is 1, 2, 3, 4, 5, 6 plus 30. So it is satisfying this criteria. Yeah. Also, you can see that there is ST depression and T wave inversion in V5, V6, 1 and AVL. Okay. This is known as Steinberg. Axis here is normal axis. Most of the times LVH would be associated with left axis deviation, but yes, sometimes the axis can be normal as well. Now let us come to the next slide, that is RVH. Okay, so for RVH, we don't have any per se any criteria as in LVH, but yes, all these things would suggest that there would be a RVH. So the R wave in lead V1 should be more than or equal to 7 mm. So R in V1 more than equal to 7 mm. Second thing is there may be right axis deviation also. Most of the cases it is there. Okay. Third thing is R to S ratio in V1, V2 should be more than or equal to 1. That is, in V1 and V2, R wave should be more than or equal to, or R wave should be more than or equal to S wave. Okay. Fourth thing is delayed intrinsicoid deflection in V1 and V2. Now, so what is intrinsicoid deflection? It is the time duration from beginning of QRS to the peak of R wave. So suppose this is the peak of R wave and this is the start of QRS. So this is the intrinsicoid deflection. So this deflection is delayed in lead V1 and V2 in case of RVH. Clear? So it would be more than equal to 0.05 m. Normally it is less than 0.0. Clear? Now we have this STT abnormality in RVH2. Similar logic would be applied here as in LVH. In RVH, there is hypertrophy of this right ventricle wall. So the direction of depolarization would be from endo to epi, but repolarization direction would reverse and it would also become from endo to epi. So there would be T wave inversion with associated ST depression in right-sided leads. That is in lead E1 and E. Clear? Now, what are the causes of RVH? Anything that would increase pressure on RV would lead to RVH. First and most common cause is LV failure or LVH would eventually lead to RVH. Second cause is cor pulmonary. So any pathology of the lung would lead to pulmonary hypertension and then it would lead to RVH. Third cause is pulmonary stenosis. Can also be seen in TOF. Can also be seen in mitral stenosis. We have these many causes of RVH. Now we can have a look at this ECG. In this ECG, you can see that this is lead V1 and this is lead V2. So in lead V1, you can see that R wave is approximately 12 mm. Okay, so in the criteria, we know that R wave in lead V1 should be more than equal to 7 mm. So it is satisfying this criteria. Then we have this R to S ratio in V1 and V2. Both are more than 1 mm, more than 1. Third thing we can look is there is T wave inversions and ST depression in V1 and V2. Also in V3 we can see here. Then we have this right axis deviation here. Okay. Clear? So these four criteria are there. That is right axis deviation. R in V1 should is more than 7 mm. T wave inversions in lead V1 and V2 and R to S ratio of more than 1 in V1 and V2. Clear? Now next slide. So in this slide we will discuss about bundle branch blocks. So the first discussion would be about left bundle branch block. So we all know that this is our heart. This is interventricular septum. This is AV node. This is bundle of his divided into left bundle branch, left right bundle. Right bundle branch goes into the right ventricle, divides into Purkinje fibers and supplies the right ventricular wall. Left bundle branch goes into the left ventricular wall, supplies the left ventricular wall. Also, left bundle branch depolarizes the ventricular septum too. Here. So when there is left bundle branch blocked, that is, here the left bundle branch is blocked. So now the depolarization of ventricular septum would not occur from left to right. Clear? So the depolarization of ventricular septum would now occur from right to left. Clear? Now here we have this lead V1 and here we have this lead V6. Okay. So in lead V1, the first deflection would be of ventricular septum, and now the ventricular septum depolarization would occur from right to left. So the first deflection is downward. Here. Now the second thing to depolarize in left ventral branch block is right ventricle, because right ventricle would depolarize from Purkinje fibers while left ventricular would now depolarize from ventricular muscle only. So it would take more time. Okay. So the second wave in lead V1 is a positive deflection. Slight positive deflection, because the right ventricular muscle mass is very less. So this deflection is because of right ventricular depolarization. And the third deflection is a very big S wave because of major ventricular depolarization, major left ventricular depolarization, which now occurs through ventricular muscle. This is a QRS in case of left ventral branch block in V1. Okay. So this complex, we can call it as QS complex. Okay. Clear? And this can also be known as W bed. We have this downward deflection and small notching and stuff. Or sometimes this notch may be absent or not appreciable. We call it as V pattern. Or in term of an ECG, we call it as QS bed. Yeah. Now in lead V6. So in lead V6, since depolarization of the septum would now occur from right to left, so the first deflection would be a positive deflection because of septal depolarization. Then a second deflection would be this notch because of right ventricular depolarization, and the third deflection would be a upward deflection due to major left ventricular muscle depolarization. This would be a QRS in lead V3. This is known as R dash complex or RSR complex. Here. Also for the similar reasons, we know in LVH and RVH, in left bundle branch block also, since depolarization of left muscle wall would now occur through muscle and not through Purkinje fiber, so it will take more time. Okay. So the direction of depolarization would be same, that is from endo to epi, but the direction of repolarization would now have to reverse because it would take more time. So the direction of repolarization would occur from endo to epi. Okay. So in case of left bundle branch block also, the T wave and ST segment would be inverted in left sided leads. Okay, so in V5, V6, 1 AVL, we have this T wave inversions along with ST depression. And in reciprocal leads, that is in lead V1, V2, we have slightly tall T waves with slight ST elevation. Here. So now we can clearly see this in this ECG. This is lead V1. We have this Q wave, small notching, S wave. This is QS wave. Okay. Or we can also call it simply as S wave. Now in this lead V6, we have this R wave, small notching, and again R wave. So this can be known as RR dash wave or RSR. And in this also we can see that there is this ST elevation, slight ST elevation and slight tall T wave in lead V1 and ST depression with T wave inversions in lead V6. This is known as W pattern, this is known as Also, LBBB is mostly associated with left axis deviation. Okay. Another thing is that LBBB is most common conduction abnormality in cardiomyopathy. Okay. And in on auscultation, in LBB patients, since S2 has two components, that is A2 and P2, and in LBBB the A2 component would delay, so we would be having this reverse splitting. Clear? Now let us look at this ECG. Okay, so in this ECG, we can see that the axis is left axis. One thing that I have missed in that is in left bundle branch block or in right bundle branch block, since the depolarization is occurring through ventricular muscle, so there would be broad QRS. We have discussed it in our first lesson 2 that there would be a broad QRS in case of bundle branch blocks. Okay, the QRS duration would be more than 0.12 seconds. This is the most important criterion bundle branch blocks. In this, we can see that the axis is left axis. The duration of QRS is almost 5 small squares, that is 0.2 seconds. So it is broad QRS, clear. It is leftward axis. Then we have this deep S waves, QS complexes in lead V1. And we have this RR dash complexes in lead V6. Or we can also say it as P pattern here and M pattern here. Also, we can see that there is slight ST elevation with tall T waves in lead V1, V2 and ST depression with T wave inversions in lead V6 and lead 1 also and AVL also. Here. So per se in this ECG, if we can write down the finding, the first thing is left axis deviation, the second thing is broad QRS, the thing is QS complexes in V1 and RR dash complexes in V6 along with T wave inversion, ST depression in 1, 6. All these things favors left bundle branch block. Here. Now, as we know that there would be ST elevation and slight tall T waves in lead V1, V2 in case of left bundle branch block. Also, there would be this ST depression and T wave inversions in lead V5, V6. So, it is very difficult to diagnose MI in case of left bundle branch block. Okay. So if there is an underlying left bundle branch block, it is very difficult to diagnose MI. So we have this Scarboza criteria for diagnosing MI in case of LBBB. In this, we have these 3 points. First point is concordant ST elevation of more than equal to 5 mm. Okay. So concordant means that if the QRS is in downward direction, the ST elevation should be in upward direction. Now this elevation should be more than equal to 5 mm. This is concordant ST elevation. as in this ECG, if ST elevation in lead V1 and V2, if these elevation would be more than 5 mm, then they would be called as significant ST elevation. But here we can see that the ST elevation in these leads are of 2 or 3 mm. So we give a score of so it is wrongly written here. Sorry, I have explained this third point here, discordant ST elevation. Okay, so if QRS is in downward direction and ST elevation in upward direction, so this is known as discordant ST elevation. So this third point here is what I have explained. Okay? So if these ST elevations of 5 mm or more in lead V1 and V2 are here, we call them as discordant ST elevation and we give them as point of 2. Then we have this another point, concordant ST elevation. That is, if QRS is in upward direction and ST elevation is also in upward direction, then if the concordant ST elevation of more than 1 mm is there, then we call it as concordant as significant concordant ST elevation and we give it a score of 5. Okay? So suppose this is lead V6. Okay, we have this upward QRS here. Now if in lead V6 we have this ST elevation of 1 mm, then it is called a significant ST elevation here, and this is known as concordant ST elevation, and we give it a score of 5. Okay? Now the third point is concordant ST depression of 3 mm, of 1 mm, and we give it a score of 3. Suppose we have this negative QRS in V1, V2 and V3. So if in lead V1, V2 or V3 there is ST depression of more than equal to 1 mm, then it is known as concordant ST depression. Okay? So if there is downward QRS and ST depression is there, so this is concordant. This concordant ST depression is given a score of 3. The total score is 10. Significant score is when the score is equal to or more than 3. I hope I am clear here. We can have this discordant ST elevation more than equal to 5 mm, given a score of 2. This concordant ST depression more than equal to 1 mm, given a score of 3. And then we have this concordant ST elevation more than 1 mm, given a score of 5. So the score of 3 or more than 3 is called significant. Then we have this modified Scarbosa's criteria. In this third criteria, that is discordant ST elevation of more than 5 mm is changed, and the actual criteria here is that if the amplitude of discordant ST elevation is at least 25% of preceding S wave. Okay, so suppose this is QRS in lead V1 and S wave is of 20 mm here. Let us suppose that S wave is of 20 mm here. So ST elevation should be more than equal to 25% of 20 mm to call it as significant ST elevation. And this score is given a score of 2 instead of this point. Okay? Or suppose if S wave is of 30 mm, so ST elevation should be more than equal to 25% of 30. Clear? Last point is what are the causes of left bundle branch loss? One cause that I have told you is cardiomyopathy. Another one can be left ventricular hypertrophy. Another causes can be myocardial infarction, ischemia. These are some of the important causes of left bundle branch loss. Then we have this another block, that is right bundle branch block. And this also, suppose this is in heart, so lead V1, this is 6. So here the right myocardium will get depolarized through the muscle, while left would get depolarized through Purkinje fibers. Direction of septal depolarization would remain same, that is from left to right. So in lead V1, first of all, we have this first positive deflection due to septal depolarization. Then we have depolarization of left ventricular muscle. We have this negative deflection here. Okay. And then we have a great positive deflection due to right muscle depolarization, which occurs through muscle fibers. Okay. So we have this pattern here. This pattern is known as RSR dash pattern, okay, or M pattern, or rabbit ear pattern. Here, in lead V6, the first deflection would be a negative deflection because of septal depolarization. Then we have this positive deflection due to left muscle depolarization. And again, we have this negative deflection because of right muscle depolarization. This is known as QRS complex. Okay. Yeah. So for RBBB, or this can also be known as in V6 W pattern. So in RBBB, first of all, the QRS duration would be more than equal to 0.12 seconds. That is, it would be a broad QRS. And we have this M pattern or RSR dash pattern in V1. And we have this W pattern or QRS pattern in V6. The catch here is that in most of the cases of RBBB, the axis is normal, while in most of the cases of LBBB, the axis is left axis deviation. Okay. Now, STT changes here also. In right-sided leads, V1, V6, we have this T wave inversions and ST depression, even in depression. Now, what are the causes of RBBB? Again, it can be idiopathic. It can be because of core pulmonary or any lung pathology. Then it can be because of mitral stenosis. It can be because of RVH. Can also be seen in case of AST. Okay. Now let us discuss this ECG. So first of all, in this ECG, the axis is normal. QRS is broad. The QRS duration is approximately 5 small squares, that is 0.2 seconds. Okay. Now we have this RSR dash pattern in lead V1, and we have this QRS pattern in lead V6. Also, we can see this T wave inversions in lead V1. So this is an ECG of RBB. Clear? Okay, so let us end today's session here only. And in next session, we'll discuss about bifascicular and trifascicular blocks. Okay. So if you have any doubt, then you can ask in the comment section. Uh, then we will have a discussion about bifascicular and trifascicular blocks in the next session.
Um, Thank you, sir. That was a very comprehensive coverage of both the chamber enlargements as well as bundle branch blocks. One question in ASD, is it really a bundle branch block, right bundle branch, or is it just it's like pseudo bundle branch wherein it's only the pulmonary trunk that is dilated? Sir? Because that doubt many people have asked.
Let us see. We have this entity called as incomplete bundle branch block also. So the difference in complete and incomplete bundle branch block is that the QRS duration is more than 0.12 seconds in complete bundle branch block, while the QRS duration is less than 0.12 seconds in incomplete branch block, along with the same pattern in complete branch block. Okay. In case of ASD, since there is this shunt from left atria to right atria, so there is obviously RA enlargement because the more blood is there in RA. Okay. Now, since when this more blood is in RA goes from RA to RB, there would be RB hypertrophy as well. Yeah. So in ASD, that is in long-standing ASD, there is RVH. Okay. And this RVH will lead to RBBB. This can be incomplete RBBB or complete RBBB. And in most of the cases, it is just incomplete RBBB. So we have that M and W pattern there, but the duration is not more than 0.12 seconds. But yes, RBBB is there. And incomplete RBBB is also a true RBBB. It is not a pseudo RBBB.